Okay, let's dive in. You know that feeling, right? You're staring down this just mountain of revision notes or complex info on a topic you really need to get a handle on, like fast.
Oh, yeah.
It's just so easy to get lost in the detail.
Hmm.
So our mission today is to take your specific notes, these ones are a really common subject, and basically turn them into something clear, memorable, and, high yield.
Exactly. We're sort of distilling it
Yeah,
down,
distilling the essential knowledge points for a quick recall.
cutting through the density. This deep dive, it's built directly from the material you sent over, focusing specifically on non-gonococcal urethritis NGU.
Right, NGU.
So we're going to walk through your notes, yeah, highlighting the really important bits and why they actually matter, whether you're revising or just want a solid grasp of it.
Perfect. So let's just jump right in then, the fundamental question from your notes. What exactly is NGU?
Okay, so at its core, NGU is inflammation of the urethra. That's the tube you pee through. But crucially, it's inflammation that's not caused by Neisseria gonorrhoeae.
Ah, okay, so not gonorrhea.
Exactly. That's the bug that causes gonorrhea, or GC. So you rule out GC, and what you're left with is potentially NGU.
Got it. Urethritis minus gonorrhea. And what are the telltale signs the notes point to, the main things?
Well, the typical presentation highlighted is urethral discharge and, discomfort or maybe actual pain when urinating.
Sounds pretty clear-cut. But the notes also clarify urethritis itself.
Yeah.
It can be caused by infections or sometimes things that aren't infections?
Precisely, yeah. But for NGU specifically, the notes really emphasize it's primarily transmitted through sexual contact, even these non-gonococcal types.
Okay, mostly sexual contact. And how does the diagnostic process usually kick off, according to this material you've got?
It typically starts with spotting those clinical signs, the discharge, the pain. Then notes mention moving towards investigation, often starting with maybe a gram stain of a urethral smear or looking at a urine sample.
Your notes also lay out a specific way to classify male urethritis. Can you break that down for us?
Sure. It's basically split into three main buckets. First, gonococcal urethritis, that's your GC.
Right.
Second, non-gonococcal urethritis NGU, which covers all the other causes, infectious and non-infectious.
Okay.
And then there's this third category, persistent or recurrent urethritis. And what's really important about that one from the notes is that it affects a decent chunk of guys, 10 to 20%, who were initially treated for NGU.
Wow, 10–20% recurrence.
Yeah, so that's a key detail to remember for follow-up, definitely.
Okay, definition and classification sorted. Now, this is where it gets really interesting from a revision angle, the causes, the etiology. If it's not GC, what are the main culprits we need to know about from your notes?
Right, this is super high yield. The notes clearly state the most common STI causes of NGU, especially in younger patients, are Chlamydia trachomatis
Chlamydia, yeah, everyone knows that one.
and Mycoplasma genitalium. These are the two big players you need to think of first.
Okay, Mycoplasma genitalium too. That's really crucial not to miss.
Absolutely. And the notes add another layer of complexity, dual infections. It's noted that having more than one infection at the same time, say both chlamydia and mycoplasma, that can happen in up to 10% of men.
10%. So you can't just test for one thing and assume you're done.
Exactly right. You got to think broader.
What about the other infectious agents listed in the notes? Any others we should be aware of?
Yeah, there are others. The notes include Trichomonas vaginalis, that's a parasite, also a specific type of Ureaplasma, urealyticum biovar 2. And they mention that sometimes UTIs, urinary tract infections, can kind of muddy the waters or contribute.
Okay.
Then there are smaller percentages attributed to things like adenoviruses, herpes simplex viruses types 1 and 2, and some other, less common infections.
So quite a mix of potential bugs.
Yeah.
But your notes also mention non-infective causes. What's the story there?
Yes, and this is actually a tricky area highlighted in the notes. A significant proportion of NGU cases, especially maybe in older patients who don't have that classic discharge symptom, they don't actually have an identifiable infectious cause.
Huh. So no infection found.
Right. And pinpointing these non-infective causes, the notes suggest, remains pretty challenging.
Okay. That gives us the range of possible origins. So who's most likely to get NGU then? The notes list some key risk factors. Why is knowing these so important?
Well, knowing these risk factors is critical, really. It helps identify people who should probably be tested, even if their symptoms are really subtle or maybe not there at all.
Right.
The notes list the ones you'd probably expect. unprotected sexual intercourse, having multiple sexual partners, a history of previous STIs, and engaging in what they call high-risk sexual behaviors.
Makes sense.
These are the kind of flags that should definitely raise your suspicion.
It's strongly tied to sexual health practices, clearly. So how does the body actually react when these pathogens, these bugs, get into the urethra? What's the pathophysiology described in the notes?
It's pretty straightforward, as outlined in the notes. The pathogens, they invade, and then they start to colonize the lining of the urethra. That's the urethral epithelium.
And that invasion triggers.
An inflammatory response, yeah.
Yep.
The body reacts, causes inflammation in the urethra, and that inflammation, in turn, leads to those characteristic NGU symptoms we talked about. The discharge, the painful peeing, the irritation.
Right, okay. So the inflammation is the direct cause of the symptoms. Now, if someone comes in with these symptoms, NGU isn't the only possibility, is it? This is where differential diagnoses come in. What else do you need to consider based on your notes?
Yeah, good point. This raises a really important question for anyone seeing patients. What else could look like NGU? The notes really highlight you need to consider other conditions that cause urethral inflammation or similar symptoms.
And the main ones to rule out or differentiate from?
Well, number one is obviously gonococcal urethritis. Like we said, you have to rule that out to even call it NGU.
Okay.
You also need to think about urinary tract infections, UTIs. Genital herpes can sometimes present this way. And then other less common causes of urethral inflammation.
And the definitive way to tell them apart, according to your source material. What do the notes say?
Laboratory testing. Simple as that. The notes strongly emphasize that lab tests are absolutely crucial for an accurate diagnosis and for telling NGU apart from these other possibilities. You just can't rely on symptoms alone.
Right, you need the lab confirmation. Okay, shifting gears a bit to the bigger picture. Let's look at the epidemiology, focusing on the UK context like your notes do. How common is NGU, really? Is it a big issue?
Oh, it's common. What's fascinating here is just the sheer volume. The notes state clearly that NGU is very common, especially among sexually active young adults in the UK.
And there's a specific statistic mentioned.
Yeah, a pretty striking one. Over 80,000 cases of urethritis, that's the general inflammation, are diagnosed every year in UK GUM clinics.
80,000.
Yeah, and within that number, the notes specify that NGU is actually more common than gonococcal urethritis.
Really? More common than gonorrhea?
Yep, that's a really significant point. In this category, NGU is the more frequent diagnosis.
That's a key takeaway right there. And how does this connect to the broader STI picture in the UK, according to your notes?
Well, it ties directly into how common chlamydia is. The notes mention chlamydia as the most prevalent STI overall in the UK, with a really high concentration in that 15 to 24 age group.
Right.
So while NGU has lots of causes, chlamydia is a major driver of these NGU numbers. The notes also give some context on rising gonorrhea rates, especially in men who have sex with men, MSM, but they reiterate that the highest rates of gonorrhea are also among young people. 56% of heterosexual cases are aged 15-24.
So NGU exists within this larger picture of high STI rates in young adults.
Exactly. It gives you that crucial context and shows who is most affected.
Okay, let's bring it back to the patient presentation then. What does the clinical picture look like? We mentioned the main symptoms, but what are the details from the notes?
So the most common things are that urethral discharge and the discomfort or pain during urination. The notes also list itching and redness as additional possible symptoms, things you might see or feel.
Okay, and this is arguably the most crucial point about NGU for anyone studying this, highlighted right there in your notes, asymptomatic cases.
Absolutely critical. The notes stress, and this is just a vital takeaway for revision, seriously, that asymptomatic cases are common.
Common, okay.
Yeah, especially in men who might also have gonorrhea or chlamydial infections at the same time. You could have NGU or another STI causing it and have absolutely no idea.
Wow.
And that's why identifying those high-risk patients we talked about earlier becomes so incredibly important. You just can't wait for symptoms to appear.
So remind us, who are these high-risk patients we should be actively thinking about testing?
According to the notes, sexually active people, males under 35, anyone reporting unprotected sex, men who have sex with men, MSM, people living in urban areas, and individuals who've had a recent partner change.
Gotcha. Okay, so you've identified someone who's potentially high risk, maybe with subtle symptoms, maybe none, or perhaps obvious symptoms. What's the recommended approach based on these notes?
The notes outline a pretty clear pathway. First step, take a full sexual history. That's absolutely essential. Then perform a local examination and also a systemic one. The notes recommend referral to a specialist GUM clinic or managing it within primary care if they offer sexual health care services.
Okay. And the specific tests to run, moving into the investigation section.
Right, the tests. The notes specify testing with a first-pass urine sample, that's FPU, and a urethral smear.
FPU and smear.
Yeah. You then manage the case based on what the smear shows, but also, and this is crucial, screen for other infections, remembering that possibility of dual infections we mentioned.
Right. Don't forget the other bugs.
Exactly. And the notes also mention considering what they call blind treatment.
Blind treatment. What's that?
It means starting treatment based just on high risk or symptoms before you get the confirmed lab results back.
Ah. Wait.
Especially for patients you think are really high risk or maybe, might not come back for follow-up, it's a practical clinical point from the notes.
Treating presumptively. Makes sense in some cases. Let's drill down into those investigations a bit more. What specifically are these tests looking for?
So the main tests are either a urethral swab or, more commonly now and less invasive, that urine sample, the FPU. These get sent off for nucleic acid amplification tests, or NATEs.
NATEs.
Yeah. The notes specifically say NATE on FPU is accurate for both chlamydia and gonorrhea, which makes it a really good go-to method.
And the urethral smear. What's the point of doing that one?
That's more of an immediate check right there in the clinic. It's looking for polymorphonuclear leukocytes, basically, inflammatory white blood cells.
It's inflammation markers.
Exactly. Finding those on the smear is a quick indicator that, yep, inflammation is present, which suggests urethritis.
Got it. Signs of inflammation right there and then. Are there other tests mentioned that might be needed depending on the situation?
Yes. Based on the patient's sexual history, pharyngeal, so throat swabs and rectal swabs might be necessary to check for infections in those places too.
Okay.
Also, a simple urine dipstick test is recommended just to quickly rule out a standard urinary tract infection, a UTI, as the cause of the symptoms. Make sure you're not missing that.
Right. Rule out the simple UTI. Okay, so you've done the tests, you've maybe got results back, or you're treating empirically. What's the general advice from the notes on how to proceed with the patient conversation and next steps?
Yeah, the notes summarize this pretty clearly. Diagnose urethritis if you actually see discharge or the patient has symptoms and is high risk, and you have supportive test results or, you're treating blindly. Then explain the likely causes to the patient, break down what NGU actually means for them. Critically, you have to stress the importance of partner notification.
Partner notification, vital.
Absolutely. So their contacts can get tested and treated too. And emphasize that the patient needs to abstain from sexual activity until their treatment is completely finished and they're symptom-free.
All absolutely essential steps for management. Now let's move right into the management itself. How do you actually treat NGU based on this material?
Okay, treatment, the core principle is targeting the pathogens, the bugs causing it. So treatment is primarily with antibiotics.
Right, and the first-line treatments listed in the notes are?
Azithromycin or doxycycline. Those are the main initial recommended options.
Okay, azithromycin or doxycycline. So you treat the patient, they take their antibiotics. What about the ripple effect? You mentioned partners.
Yes, and this is non-negotiable. The notes really stress this heavily. Partner treatment is absolutely essential. You must notify and treat sexual partners.
Why is that so critical?
To prevent reinfection of the patient, obviously, but also just to stop further transmission out there in the community. Patient education is also huge here, explaining the diagnosis, how the treatment works, prevention methods like using condoms, safer sex practices.
And tracing contacts to let them know. How far back do you need to go, according to the notes?
The notes specify tracing sexual contacts from the past 4 weeks. But, and this is a really key detail, especially thinking about those asymptomatic cases we discussed, if the patient was asymptomatic for NGU, you actually need to trace back contacts up to 6 months.
6 months if they had no symptoms. Wow.
Yeah, that really shows how important it is to try and catch those silent transmissions.
That 6-month window for asymptomatic cases is definitely a crucial point for revision. What about follow-up after treatment? Do they need to come back?
Yep, the notes recommend reviewing patients at about 2 weeks after they start treatment.
Okay, 2 weeks. And what's the purpose of that visit?
It's really for reinforcing that health education, checking they actually took the medication compliance, and assessing if their symptoms have actually gone away. Has the treatment worked?
And is there a test of cure recommended? Do they need to be retested to make sure the infection's gone?
This is clarified in the notes. A test of cure is performed for gonorrhea, definitely. But it is not routinely done for chlamydia unless there are specific conditions which aren't listed here. So for NGU generally, the focus is more on checking that the symptoms have cleared up at that 2-week follow-up.
Okay, so Less focus on retesting for NGU itself, more on symptoms resolving. What if the symptoms don't resolve, or they come back after treatment?
Right. That's treatment failure or recurrence. The notes say you should reevaluate the patient. Think about, was there a new exposure? Did they not take the meds properly? Is there a different underlying cause you missed? You might need to consider alternative antibiotics, and if it's getting complex or just keeps coming back, seek specialist advice from GUM.
Makes sense. So assuming appropriate treatment and things do resolve, what's the usual outcome? What's the prognosis described in the notes?
Generally, the notes state that NGU has a good prognosis with the right treatment. Most people recover fully without any long-term problems.
That's good news.
It is. However, your notes also quickly move from that generally good prognosis to the risks if it's not treated effectively or if that recurrence isn't properly managed.
And that leads us straight into the complications section. Why is understanding these potential complications so critical? What's really at stake if NGU isn't sorted out properly?
Well, this section really highlights why NGU isn't something you can just ignore, even though it often clears up easily. The notes list some pretty significant potential downstream issues if it's left untreated or keeps coming back.
Okay, let's run through the complications listed in your source material then. What can happen?
Right, so it can spread to other parts of the urogenital system. It could potentially lead to chronic persistent urethritis. There's also an increased risk of picking up other STIs, possibly because the inflammation makes the tissue more vulnerable.
Okay.
The notes also mention potential fertility issues down the line.
And specific inflammatory conditions beyond just the urethra.
Yes, things like epididymitis, which is inflammation of the epididymis at the back of the testicle, and/or orchitis, inflammation of the testicle itself. Also prostatitis, inflammation of the prostate gland.
Okay.
Now, interestingly, the notes also list systemic dissemination of gonorrhea here.
But NGU isn't gonorrhea.
Exactly. So its inclusion in these specific notes might be there to really hammer home the critical need to rule out GC properly at the start. Or maybe it points to the risk in those cases of undiagnosed dual infections where GC was also present alongside the NGU cause.
That's an interesting point from the notes. It kind of hints at those real-world complexities and why that initial differential diagnosis is so vital. What else is on the complications list?
Reactive arthritis is listed. That's a type of arthritis that gets triggered by an infection somewhere else in the body.
Right.
In female partners, the pathogens causing NGU in the man, especially chlamydia, can lead to pelvic inflammatory disease, PAD, and that has really significant implications for their reproductive health.
Okay, PID in partners. Big one.
Huge. And finally, the notes mention increased HIV transmission. Again, likely linked to that genital inflammation, making it easier for the virus to transmit or be acquired.
Wow, that is quite a list. It really drives home that managing NGU properly isn't just about relieving the immediate symptoms like discharge or pain. It's about preventing this whole range of potentially serious long-term health problems, not just for the individual, but for their partners too.
Absolutely. It really underlines the importance of that whole comprehensive approach. The notes describe the diagnosis, the right treatment, and especially that partner management piece.
Yeah. So looking back at this whole deep dive using your notes, we've really unpacked it, haven't we? We took the definition, peeled back the layers on all those different causes, identified who's most at risk, understood the basic mechanism of how it happens.
The pathophysiology.
Learned how to tell it apart from other conditions, seen the scale of the issue, particularly in the UK, walked through the clinical picture, including those really key asymptomatic cases.
Yeah, forget those.
Detailed the test needed, covered the essential steps of management, including that crucial partner notification, and looked at what happens both when treatment works and when it doesn't, right up to those potential complications.
Yeah, we've really synthesized the key information from your material across all the sections that were provided in those notes.
And hopefully, hearing it discussed like this, pulling out the most important points, helps make that information stick a bit better, especially those high-yield details for revision.
Hope so.
Before we wrap up, here's maybe a thought to carry away from this deep dive. Just consider the silent problem that NGU represents. That commonality of asymptomatic infection, especially with key drivers like chlamydia. It's such a significant challenge in public health, isn't it? It really demonstrates how infections can just spread unseen, potentially leading to complications for partners down the line, and just perpetuating these transmission cycles in the community.
Yeah, it's a powerful reminder that effective STI control really requires looking beyond just the people who turn up with obvious symptoms.
Exactly. It highlights that need for active contact tracing, like the notes mentioned, even when someone felt perfectly fine.
A complex challenge indeed.
And that wraps up our deep dive into non-gonococcal urethritis, based directly on the revision notes you shared with us. We've really aimed to make it as clear and high yield as possible for you.
Definitely.
Now, if you are looking for more revision materials and resources, maybe like the kind of notes we worked from today, you might find PassThemsSRA.com useful.
Yeah, and also freemsra.com both have got a range of resources that could potentially support your studies in this area.
Check them out if you're interested. Thanks for letting us dive into your material with you today.
Been great. Until next time.